The word carotid is derived from the Greek word karos, which means to put to sleep or to stupefy. In this picture, there are two statues of Greek fighters, one intentionally pressing the left carotid artery of the opponent with an intention to make him unconscious or put him to sleep to win the fight. Welcome to Stroke Rounds, episode 46.
36-year-old lactating mother who had a right hemicranial headache for 4 days and she developed left upper limb paresthesia of 2 days duration. Then on the day of admission she developed left upper limb weakness and it was increasing over time and associated with the slurred speech.
So, in a nutshell, this is a 36-year-old lady who had a progressive right facial palsy, upper and lower limb weakness, which progressed over 4 days duration. Let's see the patient. She has got a minimal left facial weakness. Right upper limb is normal. Left upper limb, she is just able to lift from the bed, probably grade 2 plus. Lower limb, she is able to lift. There is weakness, but almost grade 4 power. Beyond the window period for IV thrombolysis, the patient was shifted for a CT scan. The CT scan looks essentially normal. So, proceeded with a CT angiogram, which shows a normal arch, right brachiocephalic trunk, right subclavian, right common carotid artery, left common carotid artery arising directly from the arch of aorta, and the left subclavian artery arising from the arch of aorta. This is the left carotid CT angiogram showing the left common carotid artery, the external carotid artery, and the internal carotid artery. The right carotid artery, we can see that there is a loop in the proximal cervical segment, and when you enlarge that, beyond that, there is a dilatation followed by a very thinning, a very tight narrowing of the cervical carotid artery on the right side. The intracranial circulation looks essentially normal. The middle subal artery on both sides is normal. The MR imaging shows deep watershed infarcts here. Can see a cortical infarct in the PCA MCA border zone, which looks more like an embolic infarct, but these looks more like a hemodynamic watershed infarcts. So probably it's a combination of watershed, embolic, and hemodynamic infarcts in the right MCA territory. So the patient was shifted to the emergency room from the MRI. We was shifted on a wheelchair, but on reaching the emergency room, her power deteriorated even further. The upper limb power almost became grade 0. She was unable to lift the hand, and the lower limb power also deteriorated. In view of this deterioration, she was immediately shifted to the cath lab to study the abnormality and decide what is the best treatment option. This is the carotid artery injection showing vertebral artery injection. The caliber of the vertebral artery is small. You can see the posterior inferior cerebellar artery, the ICA on the anterior inferior cerebellar artery on opposite side, the posterior cerebral and the superior cerebellar on this side, and the opposite side is absent. This doesn't mean that it is occluded. Probably it is a fetal origin of the posterior cerebral artery, which has to be confirmed by the carotid injection. This is the left common carotid angiogram showing the normal common carotid artery, internal carotid artery, cervical segment is normal, petrous segment, cavernous segment, distal internal carotid artery is normal, dividing into A1 and MCA. And just before that, one can see the posterior cerebral artery, posterior communicating artery, continuing as the posterior cerebral artery. In the lateral view, we can see the posterior communicating artery very well, continuing as a posterior cerebral artery, which is otherwise called the fetal posterior cerebral artery. So this is the reason why in the vertebral artery injection on the left side, the posterior cerebral artery is not visualized. The right common carotid angiogram shows a normal common carotid artery, but internal carotid artery there is a gross dilatation and a tortuosity, followed by a very thinned out carotid artery and the distal carotid artery. There is a lot of irregularity here and something like a pseudoaneurysm proximally. All these features are suggestive of a carotid artery dissection. This is another view showing the pseudoaneurysm, the thinned out carotid artery. So a micro wire was attempted to be passed across the dissected segment. So as you can see from this picture, I'll show this picture once again. It is usually very difficult to differentiate between the true lumen and the false lumen, and it takes some maneuvering to find the true lumen and negotiate the wire across the dissected segment. Once the wire is negotiated across, so this is the wire across, a microcatheter also was advanced into the middle subtle artery, and the caliber of the middle subtle artery was checked. This was followed by a balloon angioplasty of that dissected, almost terminally occluded segment with a balloon. The balloon angioplasty was done. This is the balloon angioplasty showing the balloon dilated. So following which there was not much of improvement. It was almost the same. So it was decided to stent the dissected segment. Since it was a long segment, which was tortuous segment, a dedicated neurostent, which is likely to conform to the anatomy of the blood vessel, was used. A Leo stent was used. It was deployed, self-expanding stent. But even after deploying the stent, the caliber of the vessel did not improve significantly. So a wire was taken through the stent, and again a balloon angioplasty of the stent was done. So this is the uh, initial angiogram showing after deployment of the stent, and this is the balloon inside the stent. And following the balloon angioplasty of the stent, the vessel opened, or the stent opened significantly. You can see the distal portion, and the proximal portion you can see one can see the pseudoaneurysm because of the dissection. This is the post procedure MRI, which was done 24 hours later, and in this picture you can see the opened stent. And this is the picture of the patient on day 4. She showed significant improvement. The facial palsy improved significantly. The upper limb power not almost, became perfectly normal, and she was discharged on the 5th day without any significant neurological deficits. Traditionally, carotid dissections are managed medically by anticoagulation, antiplatelet medication, and most of these dissections heal over a period of time and the neurological deficits improve. But here was a patient who had a significant carotid artery dissection, and which was rapidly progressing, and in front of our eyes she deteriorated to grade 0 power. Hence it was decided to revascularize that area, and using a dedicated stent with very good clinical improvement post procedure. Please do share your thoughts, opinions, suggestions, and your comments or any other views regarding the management of this particular case. See you next time with another episode of Stroke Rounds.